In our hepatitis section, uh, we discuss hepatitis A, B, C, D, A, B, C, D, and E. So the first one is hepatitis A virus. In our previous lectures, we have learned that hepatitis A belongs to picornavirus, picoRNA virus, and in the picoRNA we have a mnemonic of perch, and in the perch H is the hepatitis A virus, and picoRNA is a naked, infectious, and positive single-stranded RNA virus. So the route of transmission of hepatitis A virus is fecal oral, and in fecal-oral the shellfish is the main culprit, along with the daycare centers and in travelers. So incubation period of hepatitis A virus is very short, like within weeks, and it causes general non-specific symptom fever, anorexia, hepatomegaly, and also elevated enzymes, all those stuff. And hepatitis A is um, not destroyed by GIT enzymes. So whenever there is a very typical thing that the children are asymptomatic, but the adults are have acute hepatitis symptomatic symptoms, and in there is a no carrier state, no carrier, there is no hepatocellular risk, prognosis is very good prognosis, and also there is no chances of hepatocellular carcinoma, no chances of carrier, and also there is a good prognosis. On microscopy, we have seen ballooning. Ballooning is the buzzword. So ballooning degeneration. What is ballooning? That the hepatocyte swells and make a balloon-like shapes of ballooning. Degeneration. Also, we have a spotty necrosis, and increase mononuclear cell infiltration, and also we have councilman bodies. So these are just general information regarding hepatitis A virus, and hepatitis A virus. We also have hepatitis A antigen and anti-hepatitis A antigen and anti-hepatitis B antigen. So anti-hepatitis A virus antigen, that is IgM, in the acute phases, and when the person is it can detect the acute virus, and if a person is immune, or it can generate anti hepatitis A virus IgG immunoglobulin, which shows that he is vaccinated or he is prior exposed to the hepatitis A virus. Then we have hepatitis E virus. So along with hepatitis A, now discuss the hepatitis E virus. So hepatitis E virus is very much common in pregnant female, expected female. First, we discuss its class. So hepatitis E virus is a Hep virus. Hep virus is a positive single-stranded RNA virus, and Hep is also naked, and also Hep are on a naked Hep, and also it's infectious. So the root cause is waterborne, like the route of transmission is waterborne and fecal-oral route, and its incubation period is very much short incubation period, and it is very much affect the pregnant female or expected female and causes fulminant fulminant hepatitis in pregnant female, which leads to high mortality and worse prognosis, high mortality in the females, in pregnant females. And also no carrier state, no hepatocellular carcinoma progression, and we have an epidemic of hepatitis E virus whenever it is the outburst, and on microscopy we have patchy necrosis. Patchy word is important, patchy necrosis, and it is also like hepatitis A virus, it is not destroyed by the GIT enzyme. This is about hepatitis E virus. Next one, we have hepatitis B virus, and in the hepatitis B section, we have known that hepatitis B is belong to double-stranded partial double-stranded DNA virus, and partial double-stranded DNA virus, it is enveloped virus, and it is also infectious. So after getting entry into the host cell, the partial double-stranded DNA virus completed its partiality and make it a complete double-stranded DNA virus. This DNA virus uses host RNA polymerases to make viral messenger RNA, and this viral messenger RNA is used by the hepatitis B DNA polymerase. This viral messenger RNA is used, go to the viral DNA polymerase, which transcribes viral DNA polymerase, which reverse transcribes this messenger RNA into the DNA partial double-stranded DNA virus, and also this messenger RNA makes the viral proteins. Also, it makes the viral envelope proteins, and this reverse transcribed partial double-stranded DNA virus goes to next to the progeny. So this is a very different mechanism, because this virus uses both RNA and DNA mode of activities. Then we have the mode of action. The route of transmission is via blood, mean it can spread via parenteral, and also it is via sexual, and also via perinatal or birthing. And whenever a person get infected with hepatitis B virus, there is a long incubation or years or months of incubation periods. And after the incubation, the person having the initially, he feels some serum sickness symptoms like fever and joint problems, joint pain, skin problem, urticaria, lymphadenopathy, and afterward it is transformed into carcinoma. So there is, yes, the carrier state. There is a hepatocellular carcinoma risk, and uh, there is chances of carcinoma development, progressive carcinoma. On microscopy, we have seen the granular appearances. The granular appearance is the aggregation of hepatitis B surface antigen, and there is also eosinophilic ground glass appearances on microscope. And eosinophil, this is also homogeneous pale pink, which is very homogeneous pale pink. This is the mnemonic used in the questions. So pale pink, homogeneous, and also we have cytotoxic T cell mediated damage, and this T cell mediation is against the hepatitis surface antigen, hepatitis E antigen, and this damage causes hepatic damage. It can cause hepatic damage. Not the virus causes hepatotoxicity. The body's immune system recognize those surface antigen and produces cytotoxic T cell, which damages the hepatocyte. And the also uh, what else we have left? Yes, there is an important line that in the neonates they have worse prognosis. Why? Because neonates has immature immune immune system. They have immature immune system. They have worse prognosis, and adults resolve, and there is an adult resolution of this virus. Adults fully resolve this virus. So this is very common, because in the hepatocyte, in the hepatitis A virus, we have learned that children are asymptomatic, but in hepatitis B, children are very much affected. So extra hepatic symptoms are manifestations are hepatitis can cause aplastic anemia. Also, it can cause pan, polyarteritis nodosa, and it can cause membranoglomeraulonephrititis, more membranoglomeraulonephrititis than membranoproliferative glomerulonephritis. So, kidney damage, vessels damage, and blood damage. The next virus, which is closely related to hepatitis B, is hepatitis D virus. Hepatitis D virus. It is a delta virus and negative single-stranded RNA virus. It is enveloped. It requires polymerase, and also it requires polymerase, and also it has the same root cause like blood, baby, and birthing. It can have the same symptoms, the same progression. All the things are very much similar to on microscopy. There is also a same microscopy appearance, but the main difference is similar to all are similar to hepatitis B virus. So I'll discuss some exception of hepatitis D virus, that it require hepatitis B envelope proteins or entry proteins in order to gain access to enter into the host cell. Without hepatitis B, there is no hepatitis D. Whenever we universally vaccinate whole world with the hepatitis B virus, then we can eradicate hepatitis D virus. It has a defective replication, because it cannot survive on its own. So hepatitis D, whenever there is a super infection, like a person is infected with hepatitis B virus, and now he is infected with hepatitis D virus, then it has a worse prognosis and a short incubation period. And whenever the hepatitis D is infected with hepatitis B virus, then it has a relatively good prognosis, and also it has a long incubation period. Also there is a prognosis. Also there is all the similarities with hepatitis B. There is initial serum sicknesses, and also there is a microscopy hepatocellular chances, so this is all about hepatitis D virus. Now we discuss hepatitis C virus. Very typical, very very much different. So hepatitis D virus, the first thing we are going to learn about hepatitis C virus. First, hepatitis C is belong to flavivirus. So flavi is in our positive single-stranded RNA virus, and it is also infectious, but it is enveloped virus. And flavivirus. So hepatitis C lack 3N2 5N exonuclease activity. And what are the consequences of lacking this activity? That there is no proofreading. Whenever there is no proofreading, there is a lot of errors in replication. And whenever no proofreading, there is a lot of errors in the replication process in the nucleoside in the DNA. So we have the antigenic variation. So antigenic variation leads to the constant production of the different serotypes of hepatitis C virus. So the host cannot cope up with the hepatitis C virus, and also there is no vaccination against the hepatitis C virus. That's why it's very much deadly. So hepatitis C has, yes, it has the carrier state. It progressed to hepatocellular carcinoma, and it is also having the longer incubation period, long incubation period. And on microscopy we have the lymphoid aggregates. Also we have the hepatic macrovesicular steatosis. So on microscopy we have seen macrovesicular steatosis, lymphoid aggregation. So majority of the people having the stable majority have the stable chronic hepatitis, and it is also progress to hepatocellular carcinoma. So the route of transmission of hepatocellular carcinoma is the transrenal route, and in the transrenal route we have the primary intramuscular IVDUs devices, and also transfusion, post transfusion is the route of transmission of hepatitis C virus. So there are a lot of extra hepatic manifestations. First one is blood related. So blood related we have the mixed cryoglobulinemia. We can have the ITP. We can have the acute hemolytic anemia, and also non-Hodgkin lymphoma. So in the kidneys we have membranoproliferated glomerulonephropathies, and is more than the membranous glomerulonephropathy. And in the endocrine section we have the increased risk of diabetes mellitus, and also autoimmune hypothyroidism. In the skin section we have the porphyria cutanea tarda, and also we have lichen planus. And in the vasculitis we have the leucocystoclastic vasculitis. So after this hepatitis we have a few things left. Whenever a person is infected with hepatitis B surface antigen, it means that there is acute inflammation or acute hepatitis IgM. And in the window period IgM is always positive. So IgM is positive. So when the marker is hepatitis B E antigen, it means that there is a high replication, high viral load, high replication is very high. So there is a high chances of transmissibility. So transmission ability is very high. Whenever there is a core antigen, core antigen mean the antigen associated with the core of hepatitis. So now whenever a person having the anti-hepatitis B surface antigen is high, it means that IgG, and it means that the person is either vaccinated or either recovered from the previous virus. So it means protection. And whenever there is an anti hepatitis B antigen, it means that there is low transmissibility rate. So this is all about the hepatitis lecture, and this is the hepatitis marker. We have discussed the hepatitis A, B, C, D. So this is pretty much very much tested in the boards. So it's a very high yield topic.